Welcome to the Microdosing for Healing podcast. I'm your host, Casey Garrett, and together we'll be discovering and learning from inspiring voices of healers, medicine keepers, and visionaries. Every episode, we'll explore the world of health, vibrant wellness, and natural medicine for a new era of human society. Welcome to today's episode. All right. Hello, everyone. I'm so excited to share our guest today. I am here with the Spirit Pharmacist, Dr. Ben Malcolm, who is a psychopharmacology consultant and a psychedelic educator. So he is coming and joining us from Costa Rica. If you have not heard of Ben yet, Ben is one of the most highly regarded and also honestly well-loved people in all of the psychedelic space. I have learned from him. His workshops, his webinars are incredible. And I'm really, really excited to sit down with him today and learn from him, ask him many of your questions that you have sent in, and also learn a little bit more about his path to this very interesting niche that he finds himself in today. So Ben, welcome.
Thank you so much. It's so great to be on the podcast.
Thank you. I would love for you to start with as much as you would like to share. I'm so curious how you go from, conventional science academic training, pharmacy, to becoming the Spirit Pharmacist.
Yeah. So, I think it was like I was the Spirit Pharmacist at the beginning of the day, but I didn't know it. And then I went on a very long sort of circumstantial, winding educational pathway. Maybe not that, tangential. Like it was still fairly focused in the interest I had, but I still didn't know what I wanted to do. Right. So really this started probably when I was about 14 years old and I was watching Intervention, this kind of reality TV show about addiction on A&E. And I didn't get it. Like I did not understand addiction. I didn't understand why a person would give up their friends, family, job, occupation, etc., for some kind of pile of substance or powder that was impure, and then they're not taking care of themselves. And it just really didn't make a lot of sense to me. And it was fascinating that is just like a phenomenology and human behavior that exists. And then beyond that, it was even more interesting because you have very divergent properties of drugs physically that lead to this sort of behavioral pattern. For example, you have really strong stimulants, make you stay up all night, blow up your cardiovascular system. You have really strong sedatives that can literally arrest your breathing. They're so sedating, yet they converge in this pattern of addictive behavior. So I just thought that was just fascinating and interesting. So, 15, 16 years old, I'm typing into internet search engines, different illicit drugs, your mom's dream come true, right? Your 16-year-old son come in to see what he's up to on AOL Instant Messenger or whatever. And he's got web pages open relating to methamphetamines and these types of substances. And so it was around that time, 15, 16, it must have been 2001, 2002, that I found Erowid. So erowid.org is an anecdote repository site about psychoactive drugs where persons can just type in whatever psychoactive substances they used or combination thereof. There's usually some sort of timeline and sort of some notes or trajectory of what happened. So I would kind of pick a substance and start reading into the anecdotes of these things. And after a while, this sort of pattern or trajectory would be revealed about certain types of drugs. Like if you just read 20 stories about cocaine, you sort of get the trajectory of what happens to you if you begin to use cocaine, right? And so it was fairly clear what the trajectory was for lots of addictive or maybe even prescription substances that are controlled that have an addictive kind of property to them. Whereas MDMA and psilocybin were just outliers as far as the anecdotes go. Most people were reporting a wonderful time. And even when they weren't reporting a wonderful time, they were reporting feeling better the next day and feeling satiated, feeling like I don't want to do that again for some period of time. Whereas all the other substances, it was a little bit more like, wow, what a night. But I woke up feeling like I got hit by a freight train and then thought, how am I going to get back to feeling normal again? Maybe use some more of it, right? And so I got the sense that well, first of all, I love Dennis McKenna's quote, like, there are no bad drugs, only bad ways to use drugs, right? Like, I don't think that drugs really have an intrinsic moral character to them. I think it is how you use it, right? There's no, evil in that bottle of morphine. Like, if you have acute trauma and not psychological trauma, but you are in a motor vehicle accident or something like that, something gets crushed, your femur, morphine is very helpful for you. You feel really good with it, right? It's like God's gift to man for that kind of situation. Yet, if you're overweight and have a sedentary lifestyle and there's a lot of weight on your knees and they're kind of hurting a little bit, starting chronic opioid use is really terrible for you. You're going to be even more sedentary. It's not going to relieve the pain very well. And you're going to end up kind of habituated and addicted to it. So I really got that. Well, okay. So I finished that piece. I get a little circumstantial, right? So I finished that piece on, the kind of addictive nature of lots of different types of substances, and had come across like MDMA and psilocybin and just got convinced that I wanted to try them from like reading about them. So it's different than other teenagers in that the intellectual curiosity really came before the experiential curiosity. When I think a lot of teenagers, it's the other way around. It's like they come across something at a party or whatever they get offered. They're just kind of curious, or through peer pressure, they want to dive into something, where I was very much like, I want to understand what this thing is, what I'm getting into, how I would use it, like these kinds of things ahead of time. And, just through that reading, even at 18 years old, I got this sense of like, where's the street pharmacist? Like, where's the pharmacist that tells people how Prozac interacts with their cocaine? Like, where's it? Because persons come in, and they're not doing so well psychologically, and they feel bad because they're using drugs. And, here's this antidepressant. Little do we know, it's a strong CYP2D6 inhibitor, and cocaine is metabolized by CYP2D6. So we just boosted the cocaine concentrations for the person the next time they go out and use, right? Maybe we even increased their overdose risk in some sort of like way. So I just kind of felt like, where's the harm reduction? Like, where's the education? Like, where is the kind of piece for, persons that just want to use substances in the world of cognitive liberty? Maybe not even to treat something, but just to occupy a headspace or try something out. Like, where's the education around those kinds of experiences? Because it really seems like that's the difference between it's safe and it turns out okay versus it's a complete train wreck and perhaps a tragic sort of disaster. So I knew all of this, right, by like age 17 or 18, right? And I think that that's just it. It's like, if a teenager can read on the internet for a couple years and figure out that the country's drug regulation system is profoundly broken, that's pretty sad. Right. Like, really, like, that's pretty sad. Like, overall, that by the time you graduate high school, you've figured out that the way that government regulates drugs is not evidence-based or having public health policy in mind. So I was passionate about that. I started playing didgeridoo when I was 18 years old. So this is it's an Aboriginal instrument.
Where did you grow up?
I grew up in Tasmania. So I was born in Australia and I lived there till I was age 10. It's an Australian instrument, the didgeridoo, but I didn't start playing it till I was 18. So all I say about Tasmania is it raised my awareness that the instrument existed. But it was really, I played trombone, baritone, and tuba. I played brass in middle school. And then about a year later, I was just at a flea market in Arizona and they had didgeridoos for sale. And I found out, the mouthpiece of a didgeridoo is almost exactly between a trombone and tuba. So I can make the drone sound just without trying at all because I had the embouchure from brass. And then it was about just getting the kind of like circular breathing down, right? So there was this kind of like, I played sort of a traditional instrument. I don't play a very traditional style with it. And I'd read this book, Ishmael by Daniel Quinn, incredible book, life-changing read for me. And it's all essentially about like givers and takers. Like, there's a couple different kinds of like persons on the planet. And probably like the colonialist dominant culture is really like a take kind of culture, whereas more like indigenous cultures that are in close relationship with the land, right? And that was like another part of it as I started taking some courses in undergraduate on Native American religion and really found that all of these Native American traditions, their spirituality was always tied to the land that they lived on. Like the sacredness of the world was the land they lived on. And that really like resonated with me as far as, yeah, like that is God to me. Like, I don't want to conceive of God as like some cantankerous man in the sky that throws a thunderbolt if you have sex the wrong way or something like that. It's just kind of like, that is such a ridiculous conception of what a deity is, right? Whereas, okay, what does seem worth worshiping to me? Well, the thing that gives us everything, like the planet, like the land that we live on. Like, this seems worth worshiping to me. And it was through there that I came across like sacramental uses of psychedelics, like religious ceremonies with peyote. And again, not necessarily trying it, right? But just reading about it. There was some really wonderful books in the special collections section of the UCSB library where you had to like go to the library and go into the special collections room, and the librarian would take it out, and you could like read the book in the library, and then you had to give it back to them, and they locked it back up again. Like these kinds of like books. And it was just apparent that it's like, whoa, okay, so now I've tried MDMA and psilocybin, and I've had wonderful experiences with a swim team at UCSB in a nightlife setting with MDMA, as well as at camping, like outdoor settings with psilocybin mushrooms. And that's all fun and dandy. But wow, if you eat something like peyote in a kind of a spiritual or religious container, then there's an extremely high probability that you're going to have what those anthropological texts called a bona fide religious experience, right? Today we call it the mystical experience, and that's what's studied through Johns Hopkins with their mystical experience questionnaire. But I think that was like a point where a lot of things clicked for me in that, well, there really must be a biological construct of spirituality, because all we need to do is like step on the serotonin receptor in a person's head and put them in a spiritual environment. And then all of a sudden they're having this big kind of spiritual experience. And I don't know, spirituality is a loaded term. If someone came to me and they said, I did a line of pure cocaine and I ascended into something and I had this kind of spiritual experience, I couldn't take that away from the person, right? You can't deny that some other kind of drug use is spiritual, or what is or isn't spiritual. Like, that's essentially for the person to decide. But it seems very consistent among persons' experiences that there's something special about psychedelics and that they can induce or engender these types of experiences way more frequently in people. So still didn't know what I wanted to do. I was an atheist at the time and didn't believe my life had a purpose. I was like really anti-religion, like anti a lot of like religious cliches, like, oh, everything has a purpose. And it was just kind of like, whatever, like life is chaos. Everything is absurd. Like I was very into like existentialism, like Albert Camus and like Jean-Paul Sartre was the types of like literature that I read all throughout high school. But it was somewhere, I think, in my fourth year of pharmacy school or so. And I just found myself kind of like, I'm a few months short of graduation. I racked up a pretty good student loan tab. What am I going to do? Like, what am I going to do? It's like, I have all this knowledge now, but I don't really know what I'm going to do with it. And I don't really believe I have a purpose. And that sort of seems like it's leading me to just sort of sitting around in my underwear, smoking weed and playing internet poker. It's just kind of like, this doesn't really feel like the life that I should be living. And so I started to think, well, what if life has a purpose? And I thought, okay, well, you don't have to know it has a purpose. You just have to pretend it does. Like, just pretend it does for a little while. And I started to think, okay, if I'm pretending my life has a purpose, then I need to go and figure out what it is now. And one thing kind of led to another. Mm-hmm. There was a DMT experience or a few, some ayahuasca, some really high grade LSD blotter, like mixed in there. Right. And all of a sudden things kind of became clear. There was like, dude, the thing that is most interesting to you now, after like 10 years of undergraduate and graduate school, is the thing that was most interesting to you at the beginning of the day. But now you've come full circle, right? Now you've explored all the other avenues of pharmacy, the leadership positions, the different sorts of practice settings that you could possibly be in. And that's still the most interesting thing. So how are you going to make it work? Like, how are you going to do this? And it became, well, to be a pharmacist that has a good opinion about psychedelics, I need to be an expert in mental health, and I need to be an expert in traditional psychiatric medications, because it doesn't matter if you graduate with a doctorate of pharmacy degree. If you've never seen someone with psychosis or a bipolar condition, you've never been to inpatient psychiatric units, you have no clue how antidepressants, benzos, stimulants, mood stabilizers, antipsychotics work, then you're kind of just a hippie with a soapbox and an advanced degree, but not a real subject matter expert, right? So it became like, I have to become a subject matter expert in the traditional things, because as the psychedelic renaissance is kind of coming down the pike, it's going to be integrating with the mainstream kind of way of things are practiced. And you have an ability to bridge these two worlds because you've been interested in this other world from the beginning of the day. And now you have a lot of foundational training to get into a specialty program that can give you the rest. So I applied to the second year residency at UCSD Health in psychiatric pharmacy, spent the year really going through psychiatric medications, different practice settings, inpatient, outpatient, chemical detox, juvenile inpatient, dementia units, the prison. We went to a lot of different things that year. And from there, decided to have begin my career in academic pharmacy. I like students. I like teaching. I like creating materials, right? So that was a good fit. But academia also carves out time to work on scholarly projects, and you're expected to produce scholarship as an academician. So it was going to be my platform for finally getting to write about psychedelics, because as a student or a resident, the projects that you get are the projects that your preceptor or superior thinks are interesting, right? As a faculty, you get to write about what you think is interesting, and you're kind of backed up by academic freedom in some ways. So you're maybe allowed to touch subjects that are more controversial. So that's what I did. And I did that for a number of years, almost 5 years. But the pandemic happened. I'd started Spirit Pharmacist. I'd been moonlighting on the side for a couple years already. And officially, there was just no boundaries or lines between the kind of psychopharmacology consulting with Spirit Pharmacist and the academic job. Academia is a great gig. I really enjoyed academia. I liked Western University where I was working. The people, the faculty I was working with were great. They felt like family. They threw us this amazing baby shower, when we were having our daughter. And I just remember feeling so special and loved by them. So I did not leave academia because I was really disenchanted with the university at all. But the longer you're in academia, the more they want to groom you for running the university, for like administrative types of positions. And, I was kind of like, I like students, I like teaching, I like writing and talking about psychedelics, but I don't feel like I'm cut out to be a university administrator. So by kind of the third quarter of 2020, it was kind of like, I'm going to do it. Like I'm going to be a psychopharmacology consultant full-time at Spirit Pharmacist. And there's probably a lot of other details I could like put in there, the cosmic travel log, et cetera. But that's kind of how things unfolded to get to today.
I love it so much. And I so appreciate hearing that, because when I have interacted with you and learned from you, one of the things I most appreciate of you is your range. Like you can take very in the weeds scientific principles and really explain them to everybody, depending on their background and where they're starting from. So it's kind of ideal, the path you found yourself on. While it's nonlinear, like it totally feels like coming full circle now, and honestly ideal. I feel like the farther we get, and I certainly see this in our applications and our participants coming in, I feel like pharmacists have a unique role to play and a crucial role to play in the movement. Yes, absolutely. Because of your unique expertise in pharmacy with traditional medicines, and also as we reintroduce ancient and indigenous natural medicines and the synthesis of the two, I think you guys are uniquely positioned to support people. So yeah, thank you so much for that background.
Yeah.
Shall we
Yeah, I mean,
dive in?
pharmacists are the drug experts, right? Like that's it. Is like the pharmacist is the drug expert on the healthcare team. There's nobody that knows drug treatments better than the pharmacist does. So anytime you're talking about using a drug as a treatment, it really seems like a pharmacist should be involved to me, right? And there's probably a lot that pharmacy can do in this space, right? That, like what I do a lot of is kind of screening or intake related types of things. So kind of helping in the upstream or preparation phases as far as looking at the kind of illnesses and medications persons are taking, what kind of risks or drug interactions, either their illnesses or medications could have with psychedelics, and then trying to bridge the gap and just kind of create a reasonable or safe plan that would get the person from A to B in a way that they find agreeable and kind of want to enact, right? But I've done other things like protocol design, like, emergency management protocols, things like that. In hospital pharmacy or health systems pharmacy, right, which spans hospitals and clinics, pharmacists are the ones that are designing all of the use protocols. They're the ones that are monitoring all of the inventory, right? They're the ones that sign off when something is dispensed, right, to somebody. And truly, pharmacists are just one of the most underutilized and underappreciated healthcare professionals. And it's mostly because, 70, 80% of pharmacists work in retail where you get paid for dispensing products. So what the world knows about pharmacy is they're a person that dispenses products, right? But your doctorate level training, it's a 4-year clinical degree program. So to sort of end up just being kind of a product fulfillment subordinate at the end of the day, it just kind of seems like, wow, you're just leaving so much on the table of what a pharmacist is capable of actually doing. Where probably a better treatment model would be to have healthcare teams where the physician really works on figuring out what's wrong with the person, diagnosis, right? That's what a physician is best trained and equipped to do. They have lots of background in anatomy, pathophysiology, lab workups, things like that. But when it comes to the treatments, the pharmacist knows a lot more about what's supplied, the side effect profiles, how it interfaces with the other illnesses and medications a person's taking, things like that. So it almost really should be diagnosis, conversation with pharmacist about treatment, right? And instead, it's a little bit more like diagnosis, treatment, send the order to pharmacy unless there's something egregiously wrong with it. And then it's just going to get pushed out. And pharmacy's been working for a long time to try to raise awareness or change this with fairly limited amounts of success, unfortunately. And it's also because pharmacy doesn't know how to advocate for themselves because pharmacists are everywhere, right? In the retail pharmacy, there's a pharmacist. For the insurance company, there's a pharmacist. For the government, there's a pharmacist, right? And all of these things have slightly different interests. Mm-hmm. So I remember in pharmacy school, I would literally get emails from the managed care kind of industry organization. It'd be like, support Bill 123. And then you would get some email from the independent pharmacy organization, like, oppose Bill 123. And it's like, okay, yeah. So compared to like nursing or physicians, where they come with just kind of like one unified voice of this is what we want. And it's very, very clear, because pharmacists are so diverse and they work in such a diversity of practice settings, you get these kind of conflicting voices because different players in the healthcare game have different sort of incentives or things that they desire. So a little bit more about pharmacy and why they belong in the world of psychedelic therapy or just any world that involves a drug with an intention to heal or treat, better a person. Anytime there's a drug involved and there's some level of intrinsic risk to think about, there's ways of managing that risk to make things safer. I mean, that's just a pharmacist's bread and butter, safe and effective drug use. Yeah.
Totally. And I know personally so many pharmacists, and I think pharmacists all over the country will just listen to what you just shared and they are clapping. Wherever they are listening to this, they are clapping in support, because I think so many of them feel in these positions that they're in, feel so limited. And I think what you have done is so inspiring to so many people to be an independent business organization. So I have so many questions to dive into with you, but why don't we start there? Because I think that's so inspiring to so many pharmacists who do want to serve, particularly in this space, who are have so much wisdom to share and contribute. You have such a unique business model that I would love for you to share how you have set up your business to be sustainable, to be independent, because someone who has been academically trained and in school for so many years does not get entrepreneurship training per se. So they have the impulse, but they have no idea how to set up such a thing. So I'd love for you to just share as much as you'd like about how you set up your business, because I think it is so innovative, particularly in the space of pharmacy.
Sure. Yeah. So I set up my business. It was almost like a reverse engineering process, right? So I sort of thought about what kind of practice model do I want? And I'd been doing moonlighting consulting, just kind of like one-time cross-sectional consulting for a couple of years, and had enjoyed that quite a bit. But I really felt the longitudinal relationships were missing. It was almost like every day a new facilitator guide coming out of the woodwork, and you're not really sure who they are or how well trained or what kind of experience they have or even how they work with people. And you're kind of like weighing in on aspects of their clients' stuff. But for them personally, it's kind of like, okay, an experience with MDMA. It's like, what dose are you planning on giving grandma? Right? Like these kinds of things like matter to me, right? Like rather than just kind of like the meds look clear, right? Like, well, okay, so what is the dosing plan? Because the difference between medicine and poison is dose, right? So there needs to be a little bit more of a vehicle for longitudinal relationships. So that was like something that I was like focused on when I was like creating the business models. Like, how can I create something that has a longitudinal relationship aspect to it? So I created the Member Resource and Support Program, which is a subscription-based program, because I thought, okay, that's going to allow me to have persons that I know and work with consistently. We can build relationships over time. I start to know who they are, what kind of clientele they are, what kind of things they like to work with, how they like to work. And, that's just going to make it better and safer. And, also help in establishing like some of the other goals I had, like to have a worldwide network of friends that serve high quality psychedelics to people. Like that was like something that was kind of like, I need to create that somehow. Like, how am I going to like forge these relationships? And so the member program was part of that. A lot of it was actually borrowed from academia or some other professionals that I saw, right? So the academic model would be you have a practice site as a faculty, but you're not there 40 hours a week. Maybe you're there like 20 hours a week, but I think it's more like 15 to 18 for most of them. It would be kind of like 3 days a week for a half day. And so I thought, you know what, like the one-to-one consulting I like to do, but I got to have time to create educational projects, webinar workshops, do just consulting, like psychopharm consulting, like creating protocols for people. Like I can't do 100% of my time as like one-to-one consulting. So I was like, okay, Monday, Wednesday, Friday from 8 to 1, those are going to be my consulting hours. The rest of those days are probably going to be dedicated to running the drug information service. So part of the member program, I have like a question and answer. So persons can submit questions and get just kind of like asynchronous responses. And then Tuesday, Thursday, I try the best I can to leave them open for project work or like website administration. So I wanted to create this longitudinal vehicle. I wanted to have like longer term relationships with people. I wanted to take the best of what academia offered as far as a practice model. And I really did like the kind of half day clinic 3 times a week type of thing, with the other space for scholarly types of like projects or work. Like I really like enjoyed that part of the model. When I was setting up my business, I was looking for persons that had, like sample course contracts and things like that. And I came across a person named Tamsin Horton, who's a business attorney that has a subscription-based model. And basically you pay into the subscription-based model and you get access to this library of like business templates you can use to set up your business. But part of that model was that you also got a discounted rates on consulting directly with the attorney, whereas outside the program, the rates were very high, right? And so I thought, this is a wonderful model, right? Like I can incentivize people to join the prescription program, a subscription, Freudian slip prescription program, and have this kind of like longitudinal relationship, and I can incentivize it with, instead of having, okay, I sell my courses individually, I sell my webinars as like one-off kind of events, right? So you can do that and it's yours forever, right? Or you can join the member program and you get all of my courses, all of my webinars, all of my drug information guides. So it's like almost like my Netflix library of resources, and persons are more like renting that so long as they're subscribed. So it's kind of like news alert. Like if you're interested in binging my courses and workshops, you can save lots and lots of money for joining the member program for a couple of months versus buying those programs independently. And honestly, I think that's pretty much how persons consume education. As they go through a course, maybe they go back one time to like look at something, but I'm not checking my notes from some courses like 10 years ago today. And I don't think most people are either. So I just think the way education is consumed, it may not even make sense to buy it in a yours forever kind of format. So the member resource and support program is the kind of, like I tell people, I do three things. Psychopharm consulting, yeah, you can do that individually and independently. I still do the one-time cross-sectional things. You can buy courses, webinars from me. Yeah, you can do that independently, get this yours for everything. Or you can get the best of me all in one place, which is the member resource and support program, right? The entire library of resources, a drug information service. So you got specific questions that you want me to answer. You can submit those within 5 business days. I get back to you. I started recording video responses for persons. They're really liking that. And then if we can't sort out the inquiries through the resources or the Q&A service, then I offer you discounted consultations, and you can extend that to your clientele if you're a provider or an organization. So I think that's the last piece that I wanted to say about the offer and how it's unique. Is it's kind of a no-no in the world of internet marketing to create an offer that's for more than one audience. It's like if you kind of go through like internet marketing types of stuff, it's like, know your audience, know what they eat in the morning and what they, it's like the more that you can focus on a specific type of person and craft your offer specifically for them, usually that's sort of like how it works. But I was kind of like, I want to work with individuals like patients. I want to work with alternative health practitioners. I want to work with therapists. I want to work with coaches. I want to work with organizations. I want to work with medical professionals and psychiatrists. What offer can I put together that has the sort of flexibility to meet all those needs? And that was the member resource and support program as well. So that's a little bit about the offer, kind of how it was conceived, how it's put together, how it runs. Yeah.
I love it. I think it's so inspiring. And pharmacists listening, yeah, I hope it's inspiring for all of you too. Yeah. Let's dive into questions, because I have so many fantastic questions from listeners who pre-submitted questions. One hot topic. So we are a microdosing community. So these questions I will preface, I'll say when we're specifically talking about microdosing or when we're talking about a range of high dose experience versus microdosing. So a hot topic right now is microdosing research and the science, quote unquote, proving microdosing works. Is it placebo? Is it not? What role does placebo play in the effectiveness? So I would love to get Ben's take on this, and also your thoughts on just research on microdosing specifically, because one of the things, I was on a panel a while ago on a podcast with Matthew Johnson, and off camera, outside the recording, we were talking about how microdosing is uniquely challenging to do research on because there's no way of removing all the variables in someone's life, right? Like when you're researching a high dose experience, you can put somebody in a room for 8 hours and have a controlled setting. If you're going to research microdosing, it's over a month or it's 6 weeks. Like there are so many other variables in someone's life that's impacting their experience, their emotions, their feelings, their self-perception. And so it's very hard to isolate the microdosing experience just on its face. in a traditional scientific research context. So I would love to hear your take on microdosing research in general, and also kind of the state of things in the placebo question.
Yeah. Yeah, sure. Yeah. So
please. Yes.
Yeah, very rich, right? It's probably could just rant on for the rest of our time. Yeah. So like, first of all, I think that kind of like the conversation with like Matt Johnson, right? About how, this is like a little bit more difficult because we can't like isolate it as a single variable. There's a lot of other stuff going on in person's life. So I think that the setting of microdosing really matters, right? And I do think that this kind of, microdosing is something that you kind of take and you may barely notice or forget you took it, and it's subperceptual, and you just go about your daily life. It's kind of like, really? Like, you just go about you really make absolutely zero effort to notice, do anything different, make any kind of like change. Like, it doesn't really sound that right to me. On the other hand, to play devil's advocate, I mean, you could make the exact same argument like, we don't really know how SSRIs really work because, people are taking those on a daily basis, and we don't know if they have a toxic boss, or, if there's some other stress that comes along, or, maybe that trial was conducted during the holiday season and it's a very, very hard time of year for lots of people. So that's why that trial's negative and this one's positive, or right. So I think that these sorts of problems are not necessarily unique to psychedelics or microdosing a lot of the time. And, frankly, overall, the data with SSRIs and the data with microdosing looks kind of similar to me overall, in that so far it's like, well, antidepressants, there's a lot more research. We'll be doing it for a lot longer period of time. We've got like trials that are fairly large in persons that, are ill and things like that. But overall, there's a big publication bias in the literature, and it seems like about half the clinical trials done with SSRIs don't beat a placebo, and the other half do. Placebo performs extremely well in trials of depression and anxiety overall. Like, it's actually really difficult to beat placebo. And maybe that's a good sort of segue into the next part of it, is like, when I say it's hard to beat a placebo, we're talking about beating an inert sugar pill, right? But when you're talking about the placebo effect, that's very different. That's a biological phenomena based upon expectancy of getting better. So I think sometimes, people are maybe crossing wires a little bit and thinking of the placebo effect and a placebo as the exact same thing, right? So is microdosing a placebo, like an inert kind of sugar pill? No, it's not. I mean, we have good enough experiments right now that demonstrates a person can feel a little bit different. There's a subjective sort of drug liking effect that's noticeable that separates from placebo. It doesn't take more than 13 micrograms of LSD to be able to find significant differences as far as blood pressure parameters, right? So there's a physiologic sort of effect that's detectable to it. What else? There's a few more things that have kind of been shown, like, okay, it does separate from placebo in that kind of way, right? But is microdosing right now, do we know, for example, okay, you do a course of microdosing for 4, 6, 8 weeks or something like that. Is your depression and anxiety persistently improved after the microdosing intervention is over? No, not so far. It hasn't panned out that way, right? And so I think that's where the kind of microdosing as a placebo comes from, because we're looking at trials of psychedelic assisted therapy, which produce unprecedented results from psychiatry so far, right? Which I think is like exclamation point, right? Unprecedented results, very large effect size, not needing very many numbers in the trials because the differences between the groups are just so stark at the end of the day. And that does make me more bullish about psychedelic assisted therapy overall, right? Because it's kind of like, okay, is microdosing a placebo? Is not a placebo? I don't know, right? But it's probably kind of weakly efficacious overall, whereas psychedelic assisted therapy seems like strongly efficacious, and it really just kind of like separates. But because psychedelic assisted therapy does produce this large effect, and it tends to be a rapid acting thing that produces this kind of persistent result afterwards, it seems like we've taken that result and placed the same expectation upon microdosing. right? So it's like after the intervention's over, a person should just persistently be better, right? With microdosing. So we're looking for the same outcome from psychedelic assisted therapy from microdosing. And that doesn't really make a lot of sense to me, right? Like, let's just say we take trials of SSRI antidepressants and we treat people for 8 weeks. And then we stop the antidepressant. Maybe we taper it because we know that it causes a physical dependence, whereas microdosing doesn't. You could just cold turkey microdosing, right? So you taper it and you do it fairly. 3 months later, are they going to be persistently less depressed and anxious, or are they kind of going to regress back to their baseline? It's like most drugs work while you're intoxicated with them, and then the effects wear off when the drug wears off. That's why chronic drug taking is kind of the model. Psychedelic assisted therapy is almost an anomaly in that you can use something and see an improvement that has this persistent result way after the effect of the drug has worn off, right? So when people are kind of like, microdosing is a placebo, it doesn't work for depression and anxiety, I'm kind of like, okay, well, first of all, it's not a placebo because it separates from things as far as different physiological or subjective effects. Second of all, maybe it's unfair to just expect that a person is persistently going to have less depression or anxiety after a course of microdosing, because it's sort of counter how many other drugs kind of work overall. And third of all, it's extremely early days for this microdosing research. It's like so far you do a lot of survey types of stuff, and microdosing seems incredibly hot, but you sort of suspect it's surveyed from microdosingenthusiast.com. And there's like a real kind of selection bias towards people that are very into microdosing. And you start looking at the demographics of it, and it's like, 80% of the people in the survey smoke weed and nobody uses antidepressants or something. And you're kind of like, okay, that's different than the US general population, isn't it? Like who you captured there is slightly like different, right? So the kind of like survey stuff looks very, very hot, right? Every time they've done a randomized double-blind placebo-controlled trial and looked at things like depression, anxiety, some kind of like psychological measure, it doesn't seem like there's been massive detectable sorts of improvements, but we're using healthy volunteers that have previously used large doses of psychedelics or microdosed before. So it's kind of like, if you're already healthy and you could have realized the benefits of psychedelics, what are we expecting to find or see there, right? So I get you have to start there. It's called phase 1 research. You have to just prove like the safety of your thing first, which usually involves healthy volunteers and just demonstrating like, hey, you can microdose 4 or 6 times or 8 times, and they tolerated it well and nobody had a seizure or anything like that. Maybe we can move to testing microdosing in a population that's ill now. Still phase 2, it's all about safety. It's not about efficacy yet. That's the phase 3 trial, right? So that's another thing in the world of, well, I don't know, the world of drugs generally, but the world of psychedelics is people take phase 1, phase 2 results and start making efficacy claims about it. And it's like those trials are not designed to do those kinds of like things. So microdosing is a few steps behind psychedelic assisted therapy that has, advanced phase 2/phase 3 trials that are either in the works or even completed now with the MDMA and MAPS studies for PTSD. So overall, I think the jury is kind of still out with microdosing as far as, okay, how robust is the effect from it? How long does it last? What kind of dosing regimens? And maybe there's probably a lot to be discovered there. Maybe microdosing isn't so great for anxiety conditions, but it's a great SSRI taper aid. Maybe microdosing isn't so good for melancholic depression, but gosh, it's really helpful for someone recovering from a traumatic brain injury. Right. So there's probably lots of different populations out there or indications for small doses of psychedelics beyond psychiatry. And I'm open. You hear anecdotes, you hear stories, like you get persons that have pretty wonderful results sometimes. I think the average person really says it's kind of meh, and they don't notice huge life-changing types of results. But, compared to what you're doing, where you're kind of pairing with like a transformational coaching program and really focusing on the set and setting, most persons that I encounter have just sort of tried it in their lifestyle, or tried it in their life, rather than like really paired it with like a dedicated effort to work on something or to change something. So, there's an expectancy effect. There's a placebo effect, and psychedelic means mind manifesting. So there's some articles or research that are wondering if psychedelics are like an augmenting placebo effect. It's like the placebo of it's like a mind manifested placebo. It's like the placebo effect itself is pretty strong, but maybe you add something that mind manifests a placebo effect, and then it's really, really strong. Now it's interesting. I think that there's a lot more to be discovered, and I think that what psychedelics are teaching us, really, like in medicine, truly, is about expectancy effects, how to account for those in trials, how to create stronger blinding systems generally, right? And all of these are incredibly positive things for clinical research. And I get that, oh man, there's so many ruffled feathers about if it's a placebo or not a placebo and this kind of thing. I'm really looking forward to larger trials in ill people where we get the kind of trans echocardiography, like safety data, looking at heart valve thickness and things like that.
Yeah,
Because I really want to see that data before I kind of unbutton myself and become a true advocate for microdosing, right? I'm still a little couched in the perspective overall. Yeah.
Yep. No, I appreciate that. One of the things I think that's so refreshing and also challenging at the beginning of people's practice is it's very mind bendy. There's a lot of deconditioning necessary because microdosing, at least in the context we hold it, it's very self-empowering. It's you working with the medicine and in participation in relationship. And it's such a different model than a passive prescription where you play no role in it. And so it's really hard for people to get their head around because they want to think it's apples to apples. They're replacing their microdose. They're changing Lexapro for microdosing when it could not be the furthest thing from the reality and experience. And so it's hard for people to get their heads around at first. The goal of microdosing is not to need to microdose. You get to a new set point and it's you that's doing the healing with the assistance of versus the other way around. It's a drug that's doing something to you. So I do think from everything I've seen we've now had about 800, coming up on 800 people at the time of this recording. And it has been undeniable, like in terms of our perspective, what we have witnessed, it's undeniable. There are many things that a placebo might have part of it, that it's mindset, it's coaching, it's lifestyle things, but also we have seen such dramatic physical healing too, that I could be the most wonderful coach in the world, space holder in the world. I could not take credit, for some of the degree of healing that we have seen that I think would only have been possible with the combination of someone in relationship with the medicine. So for example, to use myself as an example, I had a grand mal seizure disorder that started when I was 19 years old. I had been medicated for many years with traditional pharma. And when I started microdosing, it didn't even occur to me, I wasn't hoping, it really wasn't on top of my mind to even have an effect on my seizures because I had had them for so many years and nothing else touched them and no one could ever find the root of them. And my seizures after starting practice ceased. I've not had a seizure since. I've not had an aura since once. And I will go for many, many months without not actively practicing microdosing at all. But my nervous system has a completely new set point. And so when I started our program, I was so curious to see if other people would have the dramatic nervous system healing that I have had. Yes, absolutely. We have now had multiple people heal seizure disorders, TBI, as you referenced, migraine headaches. And so PMDD is another one that very, very dramatic results in a very short amount of time that I think we'll see what science proves out over time with more research, But as far as we have witnessed real time, there's some aspects of healing that I think are pretty undeniable to me at this point.
Yeah. Yeah. It's like when you're running clinical research, especially like early days with like something like this, where it's kind of like, we don't even know what we should be testing it for.
Right.
Like, should we be studying it for depression? Should we be studying it for staving off SSRI withdrawal? Should we be studying it for neuropsychiatric complications of Lyme disease? It's kind of difficult, right? And so there's a thing called an ecologic fallacy, right? If you measure something in 100 persons, you get a mean or an average result, and it tells you about what happened on average, but it doesn't tell you about anything to what happened to an individual. Right. So it can really be a lot of the time that you have something that you treat it in 10 people and it's just kind of meh for most people. And so you get this kind of average result. Okay, the pain score went down 1.5 points. All right, maybe we consider 2 or 3 points to be clinically significant. Their pain was not decreased to a point where we're like, yeah, they're in less pain or something like that. Right. But you've got that one person that no longer has any pain. Most people got a 0.5 point decrease. And it's like, okay, like what about the outlier? Okay. So I think that these cases that you come across where you see these like almost miraculous level of healing, it's like, yeah, these are like great zebras to write up as case reports, because then it starts creating medical hypothesis around why did this person get such a drastic benefit? Like what kind of unique features did they have? And like, how are they different than somebody else? Because that's it. It's like we need it almost like needs direction as far as like what do you study with it? Like what is the question to answer about it? Yeah,
absolutely. And so far what we've seen when research comes out, I know my community's reaction is largely they're missing so many of the things that they could be looking at, because it's through the lens of what can it be prescribed for? Is this something that we can diagnose for? So it tends to be on the addiction, on the anxiety, the things that are currently being medicated for are the things that they're testing for and researching for. Absolutely. Let's talk about the heart, because I had a ton of questions about the heart. So lots of folks wrote in who have heart conditions, who are on preventative heart medications for high blood pressure, for AFib, things like that. So a lot of the cautions that you hear about with psilocybin are around the heart. So I would love for you to touch on that and differentiate between microdosing versus higher dose journey. Yeah.
So with microdosing, there's almost like a unique hypothetical risk that they have, because microdosing as a form or modality of using psychedelics is more chronic. You know, maybe it's still sort of intermittent. You're not microdosing every day, but some protocols or regimens do microdose more than half of days. And if you're talking about a drug, microdosing LSD, it's pretty tight binding, also fairly long acting. You know, it might be fair to think that there is some level of activity almost every day if you're doing like an every other day kind of regimen or something like that. So you probably want to parse out like acute cardiovascular effects versus chronic or long-term cardiovascular effects or hypothetical risks, right? So the big one with microdosing that is just unique or different than psychedelic-assisted therapy or macrodose journey psychedelics is that if you really took it for a long period of time, there's a hypothetical risk of valvular heart disease or thickening of heart valves. This is because serotonergic psychedelics like psilocybin or LSD almost non-discriminately bind serotonin receptors. It's the serotonin 2A receptor that is most linked with psychedelic effects, but the serotonin 2B receptor they bind to with pretty tight affinity or high affinity. And these receptors are located in heart valves, and essentially they cause a proliferation of fibrotic or like scar tissue. So it's essentially like a rigid kind of building of scar tissue on heart valves that makes the heart valves less flexible over time. And there have been a number of drugs that have been removed from the market, that the FDA has removed from the market over the years that have this kind of property to them. So serotonin agonists, or drugs that stimulate serotonin receptors when they're used chronically, are extremely closely watched by the FDA, because it's just a known kind of like, yeah, you start messing with serotonin agonists chronically, you start getting into the realm of possible risk of valvular heart disease. And have I found cases of persons that have valvular heart disease that have been microdosing? Thank God, no. Right. But the fix is open heart surgery. Right. So it's a very serious kind of adverse effect. And you can find a couple of case reports out there about the person that used MDMA every weekend for a decade and then had valvular heart disease. Other phenethylamines like fenfluramine, fen was a diet drug in the 90s, was pulled from the market for risk of valvular heart disease. Methosergide, old school migraine drug, it's an ergoline. LSD is an ergoline, right? So sometimes it's like, well, mushrooms are different. And it's like, well, it's a tryptamine. But so far, what the FDA's toxicology panel knows about this toxicity is that if you got a drug with a tight binding affinity to the serotonin 2B receptor, there's likely a risk. And both LSD and psilocybin have it. I have a brilliant colleague, Kellen Thomas, who has invested a lot of time and research into this particular kind of like topic or question, because it's sort of come up. It's like, well, pharmacologically, the dose is too low, right? The dose is too low to do this. You could never possibly do it. And he's looked at different pharmacokinetic experiments of different doses of psychedelics and compared it to other drugs with known risks of this, and basically determined that the math is just on par with potentially having this kind of risk. So it's actually the sort of the biggest outstanding question with microdosing, and it forces me to basically suggest that if you are going to try microdosing, please do it in a cycle. Please do not do it chronically for 6 months, a year. Like I kind of think 3 months tops is your microdosing cycle, and you probably should take 50% of your length of your cycle off between them. So if you did a 2-month cycle, take 1 month off. If you really want to schedule a big macro dose somewhere in that month off, I'm okay with a one-time large dose administration there. But you got to give your heart a break, because if it builds up to the point that there is scarring, it's an irreversible type of thing. Whereas you can kind of get some thickening of heart valves, and as long as you stop before it's fibrotic and scar tissue, it is reversible, right? So until the FDA does trans-echocardiography studies measuring heart valves at baseline, during, and after microdosing, I'm not going to be able to have any other position except for you should cycle your microdosing and take breaks. Because it's almost going back to the placebo conversation. It's like, is microdosing a placebo or not? Okay, well, I basically put out my opinion. It's like, I don't really think so, but it might be close to a placebo or not have a large effect size to it. And boy, irreversible heart valvulopathies requiring open heart surgery from something that could have been done maybe with a placebo. I mean, that just sounds like it would be a public health disaster that would risk completely shutting down the psychedelic research agenda, I think, if it occurred, right? So it's just something that, okay, we're enthusiasts here, we're advocates here, I'm one of you, right? But let's also be conservative with what we do not know in this renaissance as it unfolds, because if we misstep and we get some of these irreversible, serious adverse reactions, then it could really put the kibosh on the whole thing. And that would just be so sad and unfortunate for all the people that actually stand to benefit. So that's the kind of chronic acute risk thing.
Yes.
Right?
I would love for alcohol and cigarettes to be put under the same microscope. Wouldn't that be nice?
Well, I think that's it, right? Is like you're talking about like the differences between it. So that was a very, very long-winded and detailed explanation, but I actually really only talked about the kind of like chronic use of psychedelics so far, right? Whereas the other part of your question was like, what about acute use, right? Mm-hmm. And these people that have AFib or hypertension or these kinds of things, right? So large doses of psychedelics acutely increase blood pressure and heart rate. Even small doses of psychedelics, like 13 micrograms of LSD has separated from placebo as far as being able to raise blood pressure, right? I think for the average adult that's healthy and doesn't have high blood pressure, the amount that it raises blood pressure is not really going to be significant in their life. But hey, you've got a 72-year-old somebody that has an antihypertensive and a cholesterol med and a bit of atrial fibrillation, and they start using something that has cardiovascular or hemodynamic increasing sorts of properties to it, and there could be some level of risk there. So I definitely think when it comes to cardiovascular stuff, it's a dose response relationship, like almost 100%. Like the higher doses have higher sorts of cardiovascular risk to them. Hypertension, hypertensive responses, hypertensive urgency that's required, clonidine, other types of antihypertensive medications have occurred in clinical trials, even with things like psilocybin. So if you're a person that has a level of pre-existing cardiovascular illness that are taking different types of cardiovascular medications, then you're probably worried more about like acute risks, things like heart attacks, strokes, going into an episode of atrial fibrillation or something like that with a larger dose use, or maybe smaller dose if you really were susceptible enough or your cardiovascular profile was fragile enough. Mm-hmm. So there really are just like two completely separate things. Like one is like a chronic adverse effect associated with like fibrosis of heart valves could happen to anybody, even without pre-existing cardiovascular illness. And the other one is more like, okay, psychedelics have hemodynamic increasing sorts of properties. They raise blood pressures and heart rates. If a person had pre-existing cardiovascular illness, that might be a risk for them, right? So they're just kind of completely different overall. But you will get people, they're kind of like, they read something about heart valve thickening, and then they're on a blood pressure medication, and they're like, oh, well, and it's like, okay, the subjects are actually, just different. Yeah.
Yes, absolutely. I get it. Yeah. And I've kept up with you on this subject, and what I've been relaying to people to break it down for them in their practice is, I think part of the issue is microdosing is being promoted as a substitute for their prescription medication. And so they think, oh, I've taken Prozac for 20 years, and now I'm going to take mushrooms for the next 20 years. That's not the way to look at it and frame it. And that's not necessary. The idea is to practice for 2 months, 3 months. And I love what we have seen happen very, very naturally with people's practice, is they start microdosing, they hit 6 weeks. Some people have a lot of benefit and positive benefit in 6 weeks. Some people take a bit longer. And so by 3 or 4 months, they're in relationship with the medicine. They're usually have their dose figured out. A lot of them get curious to do higher dose work at that point. Even those who didn't start out that way, they feel confident. They're more trusting of the experience. And I love what you shared in a recent webinar, which perhaps the future and the safest way, most efficacious way to work with medicines is to both over time. Like, don't microdose for over a certain amount of time, but intersperse it with higher dose, moderate to high dose work if you're working for therapeutic context.
I think so. I mean,
that resonated with what I have seen. Yeah.
For me personally, if you're going to get into psychedelics, take a psychedelic dose at some point. To me, that's just kind of it. It's like, I think that's it. It's like I get a lot of people actually that are quite timid of the larger doses. Maybe they've never done that. Maybe they've never even drank a beer or like smoked a joint. Like some persons are almost like substance naive, and they've heard some kind of scary stories, or they don't want to hallucinate, or they're under the impression that the outcomes for microdosing and the outcomes from psychedelic therapy just look exactly the same. So they just want to do this kind of like small thing. And I'm usually kind of a little bit more like, yeah, okay, microdosing, early days in the research, but not that hot so far. Psychedelic assisted therapy, unprecedented results from the psychiatry, FDA stamped breakthrough sorts of like treatments. It's kind of like, okay, you want to try microdosing? I'm not going to tell you shouldn't do that, right? But might be just a way of like dipping your toe in the water and seeing if it's warm a little bit. I think that there can be other good things that come out of microdosing, right? Particularly like maybe you're taking an SSRI type of medication and you have been thinking about psychedelic assisted therapy, maybe with psilocybin or something like that. But then you've just been reading all over the internet about the, serotonin toxicity, which I don't know, I don't think really is a risk of mixing SSRIs with psilocybin mushrooms. Or maybe you hear about diminished effects, which I think is a possible risk. But there's more and more research supporting that some people really can get some pretty solid antidepressant effects of psilocybin while taking their antidepressant. But who? How do we determine this? And I don't know, I've been interviewing people on this subject for the last 5 or 6 years. I haven't really noticed much rhyme or reason as far as like the agent they're on, whether it's a low or high dose, how long they've been taking it. I haven't really noticed like any kind of like clear pattern there.
I have for sure. Yeah.
I mean, I don't know. I mean, I've had people that are like taking like 200 milligrams of Zoloft for like 20 years or something, and they try a microdose and they're like, wow, I feel something. And then other people take like 10 milligrams of Paxil for a few months and they're like, it's not working. And I took like 3 grams and I just kind of, I didn't feel anything. So it's really sort of interesting, the sort of like spread of stuff out there. But sometimes instead of like, okay, let's do microdosing as like some kind of like regimen with this real intention of improving depression and anxiety, it's like, let's take a couple of microdoses with your antidepressant to see if you feel anything, because you're sort of thinking, I'm going to invest all this time and energy and, hire somebody to help me through this process. But man, I don't want it to just be a dud. I don't want it to not work. I don't want to be like incredibly disappointed. How am I going to know if I'll get some effect? And it's like, well, you could probably try some really small doses at a time that you have 4 to 6 hours to yourself, or it's a distraction-free period. You're not going to be driving a vehicle or giving a big presentation at work or something like that. And you can kind of see, is there any sort of noticed or felt effect? And I don't care if it's pleasant, beneficial, spiritual, uplifting. Like if that happens to you, great. But even if you're just taking an SSRI and you take 150 milligrams, 0.15 grams of psilocybin mushrooms, and an hour later feel a little queasy and need to like go lay down for 45 minutes or so, I'm like, test dose positive. That means you responded to it, and you're probably going to get more effect out of a larger dose. And even if the microdose was kind of buggy and unpleasant or anxiety ridden in some ways, I almost like take that as a sign that you're actually like in a good position for like an emotional breakthrough, an energetic catharsis with a larger dose. So it's sort of like, okay, you take a smaller dose and it makes you kind of nauseous and, slightly nervous in some way. It doesn't mean that the larger dose is going to be panic and vomiting, or maybe it will be panic and vomiting, but instead of being this kind of like uncomfortable thing that you just kind of have to try to work with, try to process, whatever, but your ego mind is still very much online, it's going to be this kind of thing that kind of takes you, and right, you might vomit and you might panic, but it will probably be felt as like an energetic catharsis or an emotional purging type of sensation or feeling. And if you can stay with that, and it's hard, if you can stay with that, like the kind of like negative aspects of it, and really just be as sick as you need to be, then the chances of you feeling a lot less sick afterwards are much better than if you're kind of like, oh, I don't want to feel sick. Let me just wait until this sick feeling passes. It's kind of like, okay, anytime you're in a psychedelic experience and you start thinking, I can't wait till this passes, or I should just wait it out, or it's sort of like, that's a cue for you're resisting it. You're resisting the experience, and to sort of try to breathe into the unpleasant sensation and try to feel more of it, because likely if you do that, something good will happen to you. In a large psychedelic experience, if you're really panicking, you're on the doorstep of divinity, right? It's like you shot the basketball to the mystical hoop and it's going around the rim, right? And if you can just kind of see yourself panicking and try to relax, then you'll probably go into like kind of almost like a mystical state. You can like really almost transmute from like anxious, dysphoric ego dissolution to like a mystical state just by kind of just transmuting and leaning into it rather than being like, no, make it stop. That wasn't microdosing explanation. The same principles and practices, though, it's just to a much more subtle degree.
Mm-hmm.
Yeah.
Mm-hmm.
I don't know if you agree with that or not.
Well, from what we have seen in practice is people who start with microdosing and evolve into higher dose experiences have far less fear, resistance, panic experiences when they move through their journey. There's a lot less resistance. There's a lot less challenging layers to the experience. So it kind of makes sense. I've spent a lot of time reflecting on why do we focus so much on the high dose experience, and why do people insist that that is the only worthwhile way to go? And stemming from, the 50s and 60s, I think the handful of guys that quote unquote led the last wave, it makes sense that gang would need a high dose experience. Lots of self-loathing, lots of ego, lots of rigidity, lots of cynicism in some cases. I have seen people who have those characteristics when microdosing need a much higher dose to have any effect at all.
Yeah.
On the other hand, I have artists who have had 50-year contemplative practices who are in their 70s. They have a mystical experience on a half a gram because they just don't have those layers of resistance.
Yeah.
They're much more spiritually bendy and flexible and open. So I hold space for both. I don't think one is the other, but to the factions that say you have to have a high dose experience to quote unquote get anywhere, or it has to be layers of fear and drama to move through. I have not seen that in experience, especially those people who come in with 40, 50 years of practice.
Yeah.
Before they meet the medicine. So all this we will discover over time.
That's it. Mm-hmm. We'll discover it over time. So I'm the kind of person that like I think you said at the sort of beginning is that, I really appreciate the way that you can take nitty gritty science stuff and sort of like translate it in some sort of like ways. Yeah. So that's just it, is I'm just translating the science stuff rather than trying to espouse some incredibly concrete belief about all of this, because that's just it. It's evolving rapidly and quickly. And that's incredibly exciting for something in psychiatry, right? Which has been a fairly stagnated sort of field, like to get novel treatments, novel agents, new mechanisms, things that produce rapid and robust results. I mean, that's incredible, right? Compared to really, really where we've been. And so when I say stuff like, like I'm more bullish about psychedelic assisted therapy and large dose types of things, it's just like I'm saying that because I'm reflecting the way that the science is. But that's the beauty of science, is it reserves the right to change its mind. Right. And that's it, is that so I don't even get these like people that are kind of like call themselves scientists and then they're like microdosing a placebo, case closed. It's like based on
7.
Are you not right? Don't you need more data to conclude that kind of like thing? Or so yeah, that's just it. Is I really expect the microdosing data to evolve, right? Because we don't know as much about it, and there are a lot of different indications or ways that it could be used. And yeah, I don't know, subperceptual versus minimally perceptible, controlling set and setting. Yeah, it's like we don't really even know what part of psychedelic assisted therapy is psychedelics and what part is assisted therapy yet. Whereas with microdosing, we just want to focus on microdosing versus placebo. Like, why is it fair to focus on psychedelics plus therapy with macrodoses, but it's unfair to focus on microdosing plus coaching as far as an intervention with microdosing? Like it just kind of like, okay, they're two different things, and maybe the intentions and ways of using them are different, right?
Yeah. I think that people ask me all the time, well, do I have to have a microdosing coach? Like, can I just microdose on my own? Like, what is there to it that I'm missing with the coach? And I certainly don't fault anyone if someone wants to do it on their own. I kind of did it on my own because it wasn't a thing around to hire a person to
Yeah.
help me through it. So I was just kind of like, is this normal? Is this normal? And tracking and journaling along the way. But I do think it's such a different, it requires so much getting outside of our conditioned mind to the way to work with an external substance, to work with nature or spirit or a drug, whichever angle we come at it. It's such a new way of thinking about it. And that's where I think the magic of having the support, a coach, a therapist, a guide, can really, really continuously reflect back to you that it's you. Like at the end of the day, it's you that is doing the healing. This is just an ally in your process. Yeah. It's a very different way of thinking about it than we have grown up with.
Yeah. I think that is like that to me, that is like the major difference between like an SSRI and psychedelics or a microdose per se, right? Is that both of them are drugs. Both of them are externalities that you ingest. Yet with psychedelics, particularly in large doses, but with small doses likely to some extent, they create experiences with high degrees of personal meaning, right? It's like the psychedelic assisted therapy. Again, it's like top 5 most meaningful experiences for that person's life. So it's a peak experience. So there's both. It's like an externality that's ingested that unlocks this experience with lots of personal meaning. And then you could take that personal meaning and do something with it in your life, or maybe just take the neuroplastic effect of psychedelics and do something with it in your life too. That's like another piece of this. I'm kind of like, okay, so what part of it is the person, talking it through or something like that versus just practically doing something different in the few days to few weeks afterwards because they're highly neuroplastic and it takes 3 or 4 weeks to entrain a new habit. So, maybe those types of like aspects that's why I'm not a huge stickler for the kind of support a person has either. I'm a little bit more like, okay, let's talk about who you are and what makes sense as far as a level of support. And if you're somebody that's been to the hospital 3 times because you have some severe trauma and you're have tried to end your life and you're on some pretty serious heavy duty kinds of medications at baseline and you want the result that they got in that trial, you should probably have some medical professionals involved and should probably be designing your intervention as close to that trial as you possibly can. Someone else, it might be a mild to moderate level of illness. Maybe it really isn't treatment refractory. Maybe they're pretty well supported in their life overall. They have a therapist already. They have a great relationship with that's open to psychedelics. They don't guide them, right? And you could, like people can put together different programs, whether it be peers and community integration support, or there be alternative healers and coaches for more like practical aspects. Like I know I just have bad habits and I need to be doing it differently versus I need to talk about my issues. I need to understand conceptually more of why I am the way I am, or I need somebody that's just an expert in reading psychedelic tea leaves and sort of what the metaphor for my life that was revealed really is, because I'm sort of confused and maybe even scared or disoriented after what happened. So yes, the trials and the research sort of like almost set like a precedent for like the level of support that you would need for that level of illness. Mm-hmm. But psychedelics are also these things that are naturally occurring sacraments. There's decriminalization movements going on as far as harms associated with recreation or illicit use of drugs, even without the kinds of support, education, and harm reduction programs that we're putting in place today. They rank pretty low as far as harm overall, to the point where as a pharmacist, I'm okay with an average adult using psychedelics even alone if they wanted to. I think that there is a lack of data supporting that the average adult that's responsible cannot put together the kind of set and setting and pick a kind of dose of substance that they would be safe using. Right? Like I think that people should have the liberty or freedom to do that. But if they're expecting the exact same result that they got in a clinical trial that used a substance 3 times and did an incredible amount of hard work and therapy between experiences and afterwards, and you think that you're just going to eat it at home one time and get that same result. I mean, like, that is apples and oranges. Like that does seem like an unrealistic expectation. Could something cool happen to you? Could you have a cool experience? Could you realize something about yourself? Could you do something with that and better yourself, even without the whatever support systems? Probably, but people tend to make a lot farther in change processes when there's support and accountability and a witness for the process.
Beautiful. Well, we are wrapping up. So I always love to ask folks, in closing, what is your vision for the field? Like, if you forecast out 10 years, 20 years, like, how would you love to see psychedelics incorporated into modern society?
Yeah.
And it's your dream, so it can be ideal.
Yeah.
Yes.
Yeah. So I put it like even like you could, like, if you go to spiritpharmacist.com and you put it in like the about page of like my website, I pretty much have it there, is that I envision in a society in which psychedelics are available in a variety of safe and supported settings for purposes of religious freedom and personal growth, for purposes of healing medical illnesses and treatments, or psychonautic experience, so long as you're in a safe set and setting and it's done with some reasonable degree of safety. So I am a psychiatric pharmacist by training. I rely on a lot of the safety data. I really follow and appreciate the science that's coming out, because the data is setting these substances free, right? Compared to 2001 or whatever, like learning about them on Arrowwood. This data didn't exist then. 20 years later, it exists, and it is setting the substances free. So it's like, I really do not want that research agenda to stop, but I also really don't want psychedelics to become pigeonholed as these things that are only for the sickest of the sickest, for the refractory kind of thing. And you have to basically try a bunch of other things that are probably weakly efficacious and riddled with side effects before you're even a candidate for that. And those things might have shot yourself in the foot to try that refractory intervention anyway. So I'm a cognitive libertarian at heart. And I think that people should be able to use the things that they want to use at the times in the lives that they want to use them for the purposes that they feel are important to them.
Appreciate you. Thank you so much. Where can folks find you?
They can find me in a variety of places. Probably one of the best places is spiritpharmacist.com. Joining my email list. I try to do weekly updates. I also send a monthly clinical digest, which I kind of break down 6 or 7 of the most impressive articles relating to psychedelic science I found in the last month or so. I am on social media, Facebook, Instagram, LinkedIn, but really the website and the email list are just the best ways to know what's kind of going on with me and just get like updates to events and research newsletters and things of that nature.
Love it. Thank you so much, for sharing with us today. And thank you, everybody, for listening. We will see you back in a couple weeks. All right. Bye-bye. Thank you for listening to today's episode of the Microdosing for Healing podcast. Are you ready to take the next step? Please visit us at microdosingforhealing.com to access our free Microdosing 101 workshop. In it, you'll learn more about our diverse community, our supportive group programs, and discover if earth medicine practice might be right for you. See you in the next episode.